We all know that prevention is a vast topic, so surely it's not possible to cover all the aspects of this topic, this important topic, in just one session and just 1 hour. But I try to emphasize just on some important points, some take-home messages that I hope it is useful for all the participants in this lecture. I try to finish my presentation in 45 minutes, and then we can have some time for question and answer or comments by you if there is any. So the main subheadings of this presentation would be something about determinants of health, then a couple of words about oral health promotion. Then we will go to the role of dentists with regard to prevention. Let me just, regarding the time, I can start here the timer to keep the time. Okay, so then we'll go to the evidence-based instructions for prevention, what a dentist should do regarding prevention for the patients. Before starting the presentation, you can see some pictures of Tehran University of Medical Sciences and its affiliated hospitals. And then you can see here the entrance of our dental school, the School of Dentistry, Tehran University of Medical Sciences. You can see here some snow. So we have snow like you, like Ukraine. Sometimes, but not like Ukraine, but sometimes we have some heavier snow, but it's rare, not usual. And you can see here some pictures of our clinical departments. In our School of Dentistry, we have clinical departments, 12 educational groups that the students attend these clinics and they grow to be a dentist. And I have visited Kharkiv National Medical University 2 times. And I'm so happy to see Valeria here, my dear friend in Kharkiv National Medical University. So I have very good memories of Ukraine, of Kharkiv and Kharkiv National Medical University. There is a good relationship between the two universities, Tehran University of Medical Sciences and Kharkiv National Medical University. We are proud of that. We had some exchange of students and staff members, and we hope to continue as we have another program coming soon regarding a virtual mobility exchange. Because of this pandemic, we could not do the real exchange this year in 2020, and probably we will not able to do it in 2021, but we hope that we can continue maybe in 2022. And I hope the situation of pandemic in Ukraine is under control. So we have heard many times that prevention is better than cure. This is a famous saying in English, and I'm sure that you have heard this. Prevention is better than cure. But why? We want to talk about why. And I would be grateful if you contribute to the discussion, because these online webinars is like I speak and speak and speak, but without any feedback from the audiences, and this makes the lecture sleepy, and you will be asleep. If you just try to participate, just maybe by writing down in the chat box, or even if you want to speak, if you want to talk, I think it's possible for you to open your microphone and talk. So for which reasons we say that prevention is better than cure? In this mode, I cannot say the chat box. So if there is anything in the chat box, I kindly ask Valeria to tell me. If someone write down something in the chat box, I would be grateful to know that. So you can think about that. You can write down the reasons that we think and we believe that prevention is better than cure. Okay, I would be happy to have your comments. I continue, but please feel free to contribute to the discussion. So probably if you think about prevention, we can count down these things, these items. We can say that prevention is simple. Preventive procedures are easy to do. Think about, for example, scaling and root planning. Think about fissure sealant therapy. Think about fluoride therapy in your office and in your dental practice. They're so easy to do. They're not some complicated and complex procedures like many other, because you know that dentistry is a technical discipline, and we have many complex procedures that we do for our patients. But prevention-oriented procedures are really simple and easy to do. So that's why one thing. The other thing is that usually prevention leads to more satisfying results. Why? Because when we are doing prevention, we preserve the tooth. We do not wait until there is some problem and then we want to restore and want to resolve the problem. And we all know that a sound tooth is stronger than a restored tooth. Regarding professional aspects and job satisfaction, I think many of you have this experience that when you are doing prevention-oriented practices, you are satisfied with the results. The other things from the patient's view is that because these preventive procedures are simple, not complex, they do not require many equipments and technical things. So they are affordable for the patients. They can afford that. You can compare, for example, scaling with implant. We all know that dental implant is the best way to replace lost tooth. But I ask you, which percentages, you can imagine that, you can think about that, which percentages of Ukraine population, they can easily afford the cost of a dental implant to be placed in their mouth. But prevention procedures, they are cheap and they are more accessible for the patients. And they are cost effective. Because in cost effectiveness, we have cost and effectiveness. So when prevention is more effective and at the same time, it has less costs, so it is more cost effective for patients and also for the profession. And we can count some other things, some other reasons that why prevention is better than cure. But I want to say that thinking at community level, if you are thinking at community level, the only way to control oral disease is prevention, nothing else. There is no other choice. If we think at community level and we want to control oral diseases at community level, there is no other choice. We cannot control oral diseases at community level just by focusing on dental treatments. We will come to this later with an interesting calculation. We will come to this later. But remember this sentence at this slide, and then in the future slide, I will tell something about that. And then if we think about the determinants of health, this is a famous diagram. You can see the factors and the determinants that affect the health of the persons and the community. We can put them in various layers, starting from, can you see my cursor in the screen? So we can, okay, thank you. We can see here at the most inner layer, we have, for example, age, sex, and hereditary factors. Then we come one layer up, and this is individual lifestyle factors. Then we can come up with social and community networks, then living and working conditions, and then general socioeconomic, cultural, environmental conditions. Usually, maybe traditionally, when we think about prevention, we think about behavior change, we think about control of diseases. We just focus on these inner and maybe in lifestyle factors. We usually forget about these really important layers: social and community networks, living and working conditions, and cultural, environmental, and social and socioeconomic status. We know that socioeconomic status has great and big effects on the health of people in the community. So if you want to control oral disease, generally all diseases, not just oral diseases, but all diseases, you should think about all these layers. And any intervention in these outer layers will result in more effective results, surely, because they are in the outer layers. This is a very good diagram. And then there is another concept, which is common risk factor approach. You can see here, and it's a schematic picture of this common risk factor approach. In this concept, it is said that instead of focusing just separate diseases, you can focus on risk factors. What is the rationale? The rationale is that one risk factor, for example, tobacco, you can see here tobacco. One risk factor will lead to various diseases. You can see here, tobacco will lead to cancer. It's a risk factor for cancer. It's a risk factor at the same time for heart disease. And you know, heart diseases are among the top diseases leading to death, top ranking, leading to death worldwide. Maybe in many years, it has been the first reason for death globally. So tobacco leads to heart disease, tobacco leads to respiratory diseases, it leads to, and at the same time, it leads to periodontal disease. And if you think about alcohol, it is a risk factor for cancer, for heart disease, and for trauma, facial and dental trauma as well. And if you think about diet, it will lead to obesity, to cancer, to heart disease, and at the same time to dental caries. So this concept says that instead of focusing just in separately on diseases, and for example, trying to control cancer in the community, we can focus on diet. We can try to modify the population diet, and then we will have more fruitful results because it leads to many diseases. And one good thing regarding this approach for us as dentists is that in this approach, our dental and oral diseases now are besides systemic diseases. For example, periodontal diseases here, dental caries, and it is besides respiratory diseases and heart diseases. So in this approach, the dental and oral diseases can attract more attention from the policy makers. So the policy makers will know that oral diseases are also important. This is one good thing about this common risk factor approach for us as dentists. Then what is health promotion? Health promotion is something beyond health education. So it is said that health promotion is equal to health education plus factor X. And what is this factor X? Here's some more details. So according to WHO in 1984, the process of enabling people to increase control over their lives and to improve their health. This is the definition of health promotion. And the factor X, which we saw in the previous slide, is something like legislation, fiscal policy, fiscal measures, taxation, and organizational changes. So without these factor X, something in factor X, we cannot expect very good results if we just focus on education, health education, and thinking about changing the lifestyle of the patients. Because lifestyle is something that is determined by many factors. But if we can just do something, for example, in taxation, in legislation, some fiscal measures, then we can say that we are doing health promotion activities. Okay, and these activities and these initiatives will lead to safer goods and services, healthier public services, and cleaner and more enjoyable environment. I told you health promotion I mean, it's not possible to cover all aspects of health promotion here, but just I wanted to tell you some hints about that. And then you can see here 3 pictures. And I remember one of my colleagues, he always saying that we have dentist of teeth. We have dentist of patient, and we have dentist of community. So if we just focus on dental problems, just focus on teeth, we are dentist of tooth, not more than that. But we should have this very important concept in our mind that oral health is a part of general health of one individual. And each individual is a member of the community. So we should think about our community responsibilities. We are also responsible for our communities, and we should think about their oral health. Not just thinking about dental health of our individual patients, but we should think about our community that we are working in. We are as professionals. It is our professional duty to think at the same time for our community, doing something for our community. Okay. Now we want to come to the responsibilities of dentists with regard to prevention. So one of the important concepts again here is that when we preserve the remain tissues, it is a kind of prevention. And we know that the goal of all dental treatments is preservation of remain tissues. Even when we are making complete denture for our patients, our main goal is to preserve the remain tissues. When we do, for example, restoration of a tooth, a single tooth, for example, amalgam filling, our first aim and our first goal is to preserve the remain tissues. So in all of our dental treatments, we are doing prevention, okay? Then we have some prevention-oriented procedures, and you are familiar with all these, for example, scaling and root planning, or fissure sealant therapy, or fluoride therapy. These are some procedures that they are prevention-oriented in nature. The other responsibility of us is oral health education. We should try to train our patients, to teach our patients how to control their oral diseases. The patients should know that control of oral diseases are their responsibilities, not us, not our responsibility, but their responsibility. And we should empower them, we should educate them, we should train them, we should convey messages to them, how to control oral diseases. And then behavior change. This is also very important. As dentists, we have the responsibility to do something regarding behavior change. Because, for example, when a patient comes to us with a decayed tooth and just to restore the tooth and nothing else, okay, what will happen? Nothing has been changed. Just we have removed the destructive tissues and we have put some artificial materials in the cavity, nothing else. So all the risk factors, all the risk-producing behaviors are in their place. So how we can expect that the patients will have no problem? The patient will surely have some problems in the future because all the factors that have led to the dental caries, they are in their place. We have just removed the destructive tissue and put some materials in the cavity, nothing else, nothing more than that. When we can claim that we are doing something really valuable for the patients, if we work on behavior change, Try to change the behavior. Try to change the self-care of the patients. Try to improve the oral self-care of the patients. And this can be done through behavior change. It's obvious, all know that just with conveying messages, just with transferring knowledge to the patients, it does not work. It does not work. So behavior change is one other aspect. We will have something about this in the end of the presentation, but I again tell that, for example, each of these topics are really broad, and they need separate sessions to go in details, to deeply go to any of these subjects, including behavior change. There are many theories and models for that, and we can select one model and we do it in our daily clinical practice. My main source for the next slides, which is about what we should do for patients in clinical practice, is this document, Delivering Better Oral Health, an Evidence-Based Toolkit for Prevention from Public Health of England, the third edition in 2017, published in 2017. A really practical and good manual and toolkit that you can use. I just go to some parts of it. And one of the strengths of this toolkit is that it is evidence-based. So it has tried to just include evidence-based, recommendations and practices. And you can see here the grading that has been used in this manual, because we will have these quotes in our next slides. For example, grade 1 is a strong evidence from at least one systematic review of multiple well-designed randomized controlled trials. And level 2 is strong evidence from at least one properly designed randomized controlled trial of appropriate size. And it comes to the last level, which is opinion of respected authorities based on clinical evidence, descriptive studies, or reports of expert committees. If you know about evidence-based dentistry, you know that with this hierarchy of evidence, you are familiar with that. This is just a brief introduction of hierarchy of evidence. So we want to go to prevention of caries in children aged up to 3 years. What should we do? Here, these are the advices that should be given to the parents of these children, 0 to 3 years old children. These are the advices that we, as dentists, in our dental practice, we should recommend the parents of these 0 to 3 years old children. So the first one, you can see with good evidence, with strong evidence, is that breastfeeding provides the best nutrition for babies. And the other things is that from 6 months of age, infants should be introduced to drinking from a free flow cup. From age 1 year, feeding from a bottle should be discouraged. We know that because this may, if the child continue to use a bottle, then maybe baby bottle syndrome or early childhood caries may occur. You know that it's very complex disease, and it's really annoying for the children and their parents. Sugar should not be added to winning foods or drinks. We should convey these messages to the parents. Parents and carers should brush or supervise toothbrushing. As soon as teeth erupt in the mouth, brush them twice daily with fluoridated toothpaste. As soon as teeth erupt in the mouth, we should start brushing for the child. The parents should start brushing for the child. Brush last things at night and on one other occasion, so two times a day. And the parents should use fluoridated toothpaste containing no less than 1,000 ppm fluoride, 0.1 per million fluoride. It is good practice to use only a smear of toothpaste. So this GP shows good practice. Maybe there is no study or good evidence for that, but it is good practice. This sign shows this. The frequency and amount of sugary foods and drinks should be reduced. And the other things about medicines. Some of the medicines for the children, they contain sugar. We should also pay attention to these. And recommend the parents that use sugar-free medicines whenever possible. Then for the children from 3 to 6 years, again, some of these are in common with the previous sets of recommendations, at least twice daily brushing, one time at night and one during the day, supervised toothbrushing, using fluoridated toothpaste,